Thank you. My name is Lee again. I'm working at International Health Center as well as Bundan Hospital. Today I'm going to talk about national system to fight the COVID and also the hospital management system to prepare for the COVID-19. So I just give a very short, brief introduction of our healthcare system. Basically, we are universal care system, meaning government holds very strong influence. But at the same time, more than 90% of hospitals and clinics are actually private. So having this universal care, so having easy access, but also at the same time, this drive efficiency by private sector with very high quality. So what happens, things like COVID-19 happens in Korea. Our Korean CDC is under the control of Ministry of Health and Welfare, and under the yellow level, then it's going to be managed in this system. However, when this alert level goes up to red, then the government will set up National Disaster and Safety Status Control Center, and then this whole structure will be controlled by the Prime Minister because of the urgency. So let me just talk about some of the key success factors that we have done so far. So as soon as the COVID-19 outbreaks happened, we have set up more than 600 spots, public and private, across country for COVID-19 screening. So these are pictures that actually set up, and these are actually private hospitals who has set up the COVID-19 testing clinic. And Dr. Kim already mentioned a little bit about this drive-through. So this is very effective, fast, but at the same time limits the exposure of frontline workers and the patient at the same time to the virus. So far we have set up around 70 spots across the country for testing. And I think this is very important. I think Dr. Kim went through the details, so I just want to once again, after outbreak of COVID-19, one of our the private company actually developed just in 3 weeks with this very good RT-PCR kit, and more importantly, through the expedited approval process, we could actually the kit was approved just in 1 week. I think you already know medical devices, these testing kits usually take 6 months, sometimes 1 year to get approval. But in time of this crisis, we have this expedited approval process, which made it easier for us to approve this product. So at the end of February, we're actually able to do more than 20,000 tests per day, more the capacity that we actually needed in Korea. So with having this RT-PCR kit, what we were able to do was that we could do very fast and thorough contact tracing, and which has led to actually more testing. So basically, our public health center officers identify patient movement in their pathway using GPS, DUR, and credit debit card user data, so we could thoroughly do the contact tracing. So at the same time, sharing this information with the public people could know that they might be contacted by this person and may have gotten COVID-19, so they can get tested. Yes, I know that there has been privacy issues and the debate is still going on, but this is set up a policy set under Infectious Disease Control and Prevention Act after MERS. And also, we needed more structures for COVID-19 patients. So basically, we transformed some of our public hospitals just for COVID-19. But at the same time, we need to maintain our routine clinical practice as well. So government designated safe hospital where patients with respiratory symptoms are isolated from other patients during the entire care process, so that these hospitals can isolate COVID-19 patients, and at the same time they could maintain routine clinical practice. And of course, we have built units for negative pressure facilities and transformed general wards using portable devices for further expansion. And in this time of crisis, the biggest problem is that a lot of times the medical facilities are overwhelmed by these patients. But we know that a lot of COVID-19 patients are actually mild, and many of the time they do not have any symptoms. So we have set up non-medical facilities, repurposed corporate training facilities and spaces. So this was for patients who can discharge from hospital but still RT-PCR positive, or patients who have comorbidities but has no symptoms. So this is example. So Seoul National University Bundang Hospital, we actually participated running this center with Gyeonggi Province, which is our local government, and we call it this community treatment center. So on top left, you see the hospital commanding center. So this is the facility in our hospital. And then we have this non-medical facility and having operating center set up. So by telecommunication, we were able to provide patient care like this. And these are real actual pictures which were set at community treatment centers. You can see the X-rays, portable X-rays here, and this is actual facilities that were provided to the patients. So basically, when patients were diagnosed with COVID-19 in Korea, they're going to be put into public or private hospitals. And if they are condition critical, they're going to send to tertiary hospitals like SNUBH, where we have high-level isolation units with respiratory machines. And when they get better, they can go home, or if they need more observation, they're going to be sent to community treatment centers for further care. So let me move on to details for the hospital management system. So SNUBH is one of a safe hospital designated by the government, and the definition is that all patients coming into our hospital with respiratory symptoms or epidemiological risk are isolated from the other patient during the entire care process. So this is a bird's-eye view of our hospital. And this is our main building, and right outside of main building, we have some COVID-19 place here. And these are our gates. And this is our ER, and in front of our ER, we have 80 trials like this. And we have high-level isolation units placed here, in other words, in our building as well. This is a simple flow chart for our triage. So whoever comes into our hospital will be screened at hospital entrance or at ER. And if they're suspicious or have some risk, they will be sent to either COVID-19 clinic or tried is ER for the further care. And they will get tested, and then they're going to be waiting home and wait for the test result. If they need admission, they're going to be sent to our ER and admitted accordingly, and I'm going to detail later. So, we have more than 5,000 or 6,000 patients every day coming into our hospital. So what we do is that we send out SMS message in advance so they can have their questionnaires ready before coming to our hospital about their recent travel history or their symptomatic status. And they'll get QR code set, and when they enter our hospital, they'll get their QR code scanned. And if there's no problem, they'll be able to get necessary care. So this is actually our main lobby of our hospital. And right outside of this entrance, we have this QR code information desk right here. And here, patients will have their QR code ready by the assistance of our staff. And when they enter our hospital, there are machines here, they're going to get QR code checked. And at the same time, they're going to get temperature checked at the same time here. So, according to their symptomatic status or epidemiological risk, they're going to be triaged and either sent to clinic or ER, or they're going to need assistance from our infection control team. So this is a real picture of our QR scanners. It's a kiosk. So when they have no problem, they're going to have this blue light. They'll be able to come into our hospital. If they have a problem, they're going to be contacted by our personnel. This is a detail for the screening process for clinic COVID-19. If they're suspected of any risk, they're going to get RT-PCR tested, and they're going to send home. If negative, we're going to send SM message. But if positive, our medical staff will call them directly and give them further instruction. But if they're not suspected of COVID-19, they're going to get issue a confirmation card, and they can get usual outpatient care. Or if what or they need just simple prescription refill, they can just get it here and go home as well. This is a more detailed diagram for our COVID-19 clinic. So basically, we have two clinics outside here, and we have for X-ray and waiting room. But of course, all the rooms are negative pressurized. And I want to show a little bit about Ppe Principles of our hospital, especially at the COVID-19 clinic. So at the restoration desk, it's rather simple. They just wear KN94 mask and long sleeve gown. But when they need to do specimen collection, they're going to have a full level D PPE as guideline says. We do regular contamination for this COVID-19 screening. So for the clinic, we do twice a day with a level D, and specimen and collection room or X-ray, we do it every patient. And we use disinfection towel with chlorine bleach 1 to 50 for the decontamination. Let me move on to our triage at the ER. So we have a 3 triage room right outside of ER. So this is our 24-hour screening center for high-risk patients. And if they are suspected of anything, any risk, they're going to be sent to the isolation area. But if not, they can just get into our routine ER and get treatment as needed. This is a picture of isolation area at our ER. So basically, we need to wear N95 respirator, gown and sleeve in all area. And in more highly suspicious area, they have to do full level D PPE when they contact patients. We have 3 areas for admission for suspicious COVID-19. So for the confirmed very severe cases, we're going to put them into high-level isolation unit, which is national designated for emergency infectious disease such as MERS or COVID-19 like now. And we have a space for moderate cases as well. And we have one more space called Preemptive Isolation Unit for pneumonia of unknown cause, or patient needs treatment but have an epidemiological risk of COVID-19. Let me go into detail a little bit more. So basically, this is a national designated units. We have 9 beds here, and entire structure is completely isolated from our building. So this was set for to fight with the new emerging infection like Ebola, MERS, but now it's dedicated for COVID-19. You can see we have a central monitoring here, and we have very big negative pressure room so that respirator, machines, CRRT, and when necessary, ECMO can all go in and treat the patient. And this is a picture of PPE donning and doffing room. As the number of confirmed patients increased, we could not just handle patients just by the 9 wards which was set up previously. So another ward was happened. So this was originally used for our respiratory symptom patient, but using more COVID-19 to fight with it, we used the portable devices and we expanded the ward. So now we have 11 more beds here to accommodate COVID-19 patients. And another is a preemptive isolation ward. So basically, this is for patients with epidemiological risk, but still not diagnosed. So, for example, people came in pneumonia, but they're not diagnosed with COVID-19 and they're going to be put here. Or if they have chest pain, abdominal pain, and they need urgent care, but they have just come from a very highly epidemic area, then they'll be put here for observation during incubation period and at the same time get necessary care. So since we have this system having COVID-19 clinic and all screening at the gate of our hospital and at the ER, inside the hospital system actually did not change that much. So in fact, face-to-face consultation there was no drastic change, but just emphasis on principle. So basically, there was no change in consultation time or setting. The only thing, doctors and patients are all wearing masks during the consultation. And we use more hand sanitizers and wash hands more often, but I want to say there was no drastic change at all. It's possible that a patient may gave us misinformation, but we do have this DUR system in our EMR, so whoever does not notice about their symptoms or contact history, but at the very final checking process before having a consultation, the problem will come in and we can manage it accordingly. And for patients who are very stable and who only needs a prescription refill for same clinical diagnosis, we ask them to, if they're possible, they want to do telemedicine, and we talked and we made the reservation for them. And then we're gonna, after the consultation, we're gonna issue the prescription to the nearest pharmacy so that they can get medication without visiting our hospital. And we are doing regular decontamination of public areas of our hospital by special companies every day. How about management of our in-hospital staff? So every day, our staff will get electronic questionnaires asking about their favorite scents or respiratory symptoms, or they have visited high epidemiologic areas. So and also if there is a new message in instruction, and this will also be sent like this for fast management. What you see here is that this is our actually cafeteria. So you see the blocking panels, right? So during the meal, we want to minimize even a little possibility of spread. And also in hospital, we are obliged to wear masks all the time and of course hand washing as much as possible. And all the conferences and meetings are converted to teleconference right now. And of course, we require more strict social distancing for our staff. I just have this slide for your reference. So this is a guideline for exposure risk of healthcare workers to patient and monitoring and work restriction, which was issued by CDC. And it's a very nice guideline. So you just go into this website and you can check it, and you can see the updates. In our hospital, have been provided to wider portion of our healthcare workers for the PPE. So many of them are now all know how to do the level D equipments. And also, we're doing simulation for CPR wearing level D. And also, we train our staff with transportation of the COVID-19 patient. So let me quickly talk about our usual practice. And so there was a patient at ER with epidemiologic risk of COVID-19. So what happened? She was 80 years old lady. She was presented with chest pain and dyspnea at our ER. However, we found that patient recently admitted to hospital, which is locked down due to in-hospital outbreaks, which put her as a high epidemiological risk patient. So what we did, we have her in isolation room at ER, and our initial management started with COVID-19 testing. But since patient had a chest pain, we couldn't wait. We started testing for the other symptoms, chest pain and dyspnea, and transferred the patient to the preemptive isolation ward as soon as possible. Luckily, patient was COVID-19 negative, so we were able to transfer to cardiology ward, and she was well. So basically, I think I've shown these pictures. This is our ER. Since she was suspected, she was going into isolation ward and moved to preemptive for further care. So let me summarize my talk about our hospital a little bit. So basically, you can see here operational observation, hands-on practice, and you can see a lot of healthcare professionals from the world are coming to our hospital, and I think SNUPH is where doctors want to visit and learn. But not just the medical side, we have provided hospital management programs to leaderships in Moscow as well. So in 2018, more than 100 Moscow hospital CEOs came to our hospital for our program to learn about our hospital system, and also a lot of nurses leadership came to our hospital as well. So I'm confident to say not just medical, but about hospital management system, we are ready and to share our knowledge and know-how. So this is my final slide. I think a lot of people talked about post-COVID-19 before, but I think it's now we are talking about new normal. So it might not be able to go back to where we were like this, at the clinic like this, but having this COVID-19 clinics screening system, screening at the gate, and having quarantines after travel, and using level D when necessary. And I think if we adopted this kind of new management system, I think we can effectively fight COVID-19 effectively.